Welcome back, everybody. For this lecture, we're going to take a focused, practical look at pneumothorax, thoracostomy, and chest tubes in the transport environment. This is one of the highest stakes topics that we'll cover because tension pneumothorax is both rapidly fatal and highly treatable if you recognize it and act quickly. Goals in this session are to make sure you can identify the different types of pneumothoraces, know when decompression is indicated, understand where and how chest tubes are placed, and manage your patients safely during ground and air transport. As we go, I want you to picture either the aircraft cabin or the back of the bus, not just the textbook diagrams, because that's where these decisions actually happen. All right, let me walk you through what I want you to be able to do by the end of this lecture. First, I want you to be able to define and differentiate the major pneumothorax types: simple, tension, open, traumatic, and iatrogenic, and describe how each presents in the field. Second, I want you to recognize the key clinical and radiographic signs of pneumothorax and tension pneumothorax so that you can act decisively rather than hesitating. Third, I want you to be able to explain when needle decompression is indicated, where to perform it, and what pitfalls to avoid. Fourth, I want you to understand the basics of tube thoracostomy, including the standard insertion landmarks, how the drainage system works, and what problems can arise during transport. And then finally, I want you to practice mentally integrating all of this into a transport plan. What equipment you need within reach, how often to reassess, and what to do if your patient deteriorates en route. Before we talk about air in the wrong place, I want to make sure we're clear on the normal thoracic anatomy. The visceral pleura is the thin membrane tightly adherent to the lung. The parietal pleura lines inside of the chest wall, diaphragm, and mediastinum. Between them is the pleural space, really a potential space that normally contains only a small amount of lubricating fluid and negative pressure that keeps the lung expanded against the chest wall. When air enters this space, the lung recoils inward and partially or completely collapses. The mediastinum, home to the heart, the great vessels, the trachea, the esophagus, that is particularly important in tension pneumothorax because rising pleural pressure can shift this entire compartment, compressing venous return to the heart and collapsing the contralateral lung. That is the mechanism of cardiovascular collapse in attention pneumothorax. This slide ties our earlier thoracic pressure lecture directly to pneumothorax. Under normal conditions, pleural pressure is negative relative to atmosphere, which keeps the lungs expanded. In a simple pneumothorax, air enters the pleural space and pleural pressure rises towards atmospheric. The affected lung partially collapses, but the mediastinum is usually stable and venous return is usually maintained. In a tension pneumothorax, that air becomes trapped, and each breath adds more air. Pleural pressure becomes more positive, the lung completely collapses, and the mediastinum shifts. This shift compresses the vena cava, it drops venous return, and it causes obstructive shock. In transport, positive pressure, ventilation, and altitude changes both accelerate this process. A small, stable pneumothorax in the ED can become a tension pneumothorax in the aircraft or the ambulance if you don't anticipate it. Let's ground ourselves in a simple definition. Pneumothorax is air in the pleural space causing partial or complete lung collapse. That air can come from a spontaneous bleb rupture in a tall, thin young person. It can come from underlying lung disease like COPD. It can come from blunt or penetrating trauma. It can come from barotrauma in a patient on a high pressure mechanical ventilation, or from procedures such as central line insertion or transbronchial biopsy. Clinically, the impact of a pneumothorax is reduced lung volume, impaired oxygenation, increased work of breathing, and if the air continues to accumulate, progression towards tension physiology. In transport, your mindset should be that any patient with a chest trauma or any patient on positive pressure ventilation has a possible pneumothorax until you convince yourself otherwise. That mindset can keep you from being surprised at a sudden deterioration. Types of pneumothorax. So this slide gives us the taxonomy for the rest of the lecture. A simple pneumothorax is air in the pleural space without hemodynamic compromise. The patient may be dyspneic and hypoxic, but blood pressure and perfusion are preserved. Tension pneumothorax is the emergency. That's where air is trapped under pressure, the mediastinum shifts, venous return collapses, and shock ensues. Um, an open pneumothorax or sucking chest wound that involves a large defect in the chest wall that equalizes the intrathoracic and atmospheric pressures, and air moves in and out of the defect with each breath. Traumatic and iatrogenic pneumothoraces, those simply reflect mechanism. So chest trauma or medical procedures as the cause. Ventilator-associated pneumothorax reminds us that positive pressure ventilation can cause both and worsen pneumothorax, especially if the plateau pressures and the PEEP are high. Clinical recognition is where you win or lose this diagnosis. For a simple pneumothorax, common findings include unilateral decreased or absent breath sounds, pleuritic chest pain, dyspnea, and tachycardia. With a tension pneumothorax, you're looking for red flags like severe respiratory distress, hypotension, JVD or jugular venous distension, and sometimes, but not always, tracheal deviation away from the affected side. The chest wall may appear more distended on the involved side. In the ventilated patient, the tension pneumothorax often presents as a sudden rise in peak airway pressures, a drop in SpO2, hypotension, and difficulty bagging if you're bagging the patient. Um, that's a dopes mnemonic moment for you if you want to go back and review that. In flight, if you're in the air, any abrupt deterioration in an at-risk patient after an altitude change has to make you think, or should make you think about an expanding or worsening pneumothorax. When you have a suspected pneumo, um, imaging can help, but never wait for imaging to treat a crashing tension pneumothorax. On an upright chest x-ray, a pneumothorax appears as a sharp, visceral pleural line with absent lung markings. The lung may appear collapsed and retracted toward the hilum. And in the tension pneumothorax, you may see a mediastinal shift. On a supine film, the findings are really subtle. Look for the deep sulcus sign, increased lucency over the anterior chest, and a depressed diaphragm. Um, CT, a CT scan is the gold standard for small or complex pneumothoraces, but it's almost never available during transport. Point of care ultrasound is increasingly, a go-to in the field. Um, Normal lung shows sliding of the pleural line and a seashore type pattern on M mode. Pneumothorax shows an absent sliding and a barcode or a stratosphere sign. If you see any of those ultrasound findings in an unstable patient, don't wait to intervene. Let's talk about treatments for pneumothoraces. We've got needle decompression, we've got thoracostomies or chest tube insertion. So let's start with needle decompression. Needle decompression is a life-saving procedure when it's used appropriately, and it's useless or harmful when it's used reflexively or not appropriately. The primary indication is suspected tension pneumothorax in a patient with respiratory distress and hypotension, particularly when the mechanism supports it. So chest trauma, barrel trauma on a ventilator, or a known pneumothorax that's deteriorating, getting worse, or getting bigger. In a pre-arrest or a peri-arrest trauma patient with unilateral chest findings and hypotension, your threshold for decompression should be very low. The risk of doing nothing is far higher than the risk of decompressing. In a more stable patient, you should seek physician input and imaging if possible before decompressing. Um, but there are really no absolute contraindications in a crashing patient with strong suspicion. Um, but you should be aware of factors that increase the risk of failure or misplacement of the needle, such as patients of size, chest wall deformities, any kind of significant subcutaneous edema, um, subcutaneous emphysema, and uncertainty about the site or the location of the actual pneumo. So sites and technique, where do you put it? Well, there's been a lot of debate about the best needle decompression site, and I want you to understand the rationale. The traditional site is the second intercostal space at the midclavicular line. But multiple studies have shown that in many adults, especially those who are obese or very muscular, standard length angiocatheters simply don't reach the pleural space. The fourth or fifth intercostal space at the anterior or the mid-axillary line actually offers a more consistent chest wall thickness, which is why many trauma systems have moved to that site as their go-to for needle decompression. Um, when looking at what to use, usually you would use a large bore 14 to 10 gauge catheter, insert it just above the rib to avoid the neurovascular bundle. Advance it until you feel a give and hear or feel a rush of air. Then advance the catheter off the needle and remove the needle. Um, at that point, you should secure the catheter and then reassess breath sounds and the hemodynamics and already start thinking about definitive chest tube placement as soon as conditions allow, even if you have to wait until you get to the hospital that you're en route to. In terms of complications and failure of needle decompression, in terms of doing what it's supposed to do, know that needle decompression is not a magic bullet, and you need to understand how it can fail. One of the most common failure modes is simply not reaching the pleural space, whether the catheter is too short, or the patient's chest wall is too thick, or your site or angle is off. In that case, air may actually track into the subcutaneous tissue, producing more subacute emphysema without relieving the tension. Um, if you have any misplacement into the lung parenchyma or a vessel, that's rare but serious. And yeah, always be meticulous. Pay very careful attention to the landmarks for insertion, which greatly minimizes these risks. Um, Even when the catheter is correctly placed, it can kink, it can clog with blood or tissue, it can be compressed by the patient positioning or the equipment in the aircraft or the ambulance. Never assume that, oh, I decompressed, so the problem is solved. Always continue reassessment. Always treat the needle decompression as a bridge to a possible chest tube whenever possible. Switching gears to chest tubes are and have always kind of been the definitive management for most clinically significant pneumothoraces and many hemothoraces or hemac or hemothorax, blood in the space. Indications for a chest tube uh, or tube thoracostomy, as the official term is. Um, those include a large or symptomatic pneumothorax, particularly in a patient who will receive positive pressure ventilation, because PPV can rapidly turn a moderate pneumo into a life-threatening one. Tension pneumothorax that you initially treat with the needle decompression usually still needs a chest tube. The catheter is a temporary vent, not a permanent solution. If you have patients with a hemothorax or a hemopneumothorax, those require continuous drainage, monitoring of blood loss, and the ability to detect ongoing bleeding. Um, all functions of a chest tube system. Um, and then finally, recurrent or persistent pneumothoraces, particularly in patients with underlying COPD or interstitial lung disease. Those often require tube thoracostomy for definitive management, no matter what. So the idea is, of course, to do what you can in the field to allow your patient to have the best care until they get to their destination. Chest tube insertion and landmarks and the triangle of safety. The chest tube insertion site is not random. It's deliberately chosen to minimize complications and maximize effectiveness of the chest tube mechanism. The classic triangle of safety is bordered by the lateral edge of the pectoralis major, the anterior border of the latissimus dorsi, and the line just above the nipple level, roughly at the fifth intercostal space. Within this triangle, the typical insertion site is the fourth or fifth intercostal space at the anterior to mid-axillary line. And the diagram here kind of gives you an indication of that. The tube then is inserted just above the rib to avoid nicking any of the intercostal nerves or vessels, which run along the inferior rib margin, both above and below. So you always want to go between. Um, as a transport clinician, you may or may not be placing the tube, but you should always know where it should be. If you see a tube inserted very high, very low, or say far posterior to the triangle of safety, Note the potential for malposition and be extra vigilant, that's a good one. Extra vigilant for complications such as an ongoing pneumo or even organ injury. Whether or not you're the one placing the chest tube, understanding the technique and the layers helps you to recognize and manage any problems that might arise. The tube it passes through the skin, through the subcutaneous tissue, through the intercostal muscles, and through the parietal pleura into the pleural space. The preferred technique uses a small skin incision just over the rib, a blunt dissection with a clamp down to the rib, and then a controlled push through the pleura, followed by a finger sweep to confirm entry into the pleural space, and then check for adhesions or lung tissue. If you did that, you went too far. Um, Only then is the tube advanced, typically posteriorly and superiorly for air, or posteriorly and inferiorly for fluid, depending on what the underlying issue is. Placement is confirmed by a number of things. So, um, use your clinical assessment. So, improved breath sounds, chest rise, appropriate drainage into the chest tube system, and imaging if you have it available. In transport, always double check that the tube is well secured and that the drainage system, if there is one, is functioning properly before you move, because it's a lot easier to deal with any issues or complications of the actual setup at the stationary site rather than when you're on the road. The water seal chest tube drainage system. I remember learning about that back in school many years ago, and it always confused me. So here I am talking to a computer and trying to explain it to the ether. But here goes nothing. So understanding the chest tube drainage system is absolutely critical for safe transport of a patient who's got one. Most systems have three main components. They've got a collection chamber for blood or fluid, a water seal chamber that acts as a one-way valve, and a suction control chamber, wet or dry, that regulates negative pressure when suction is applied. The water seal that prevents air from re-entering the pleural space. Gentle intermittent bubbling can indicate an air leak, while vigorous continuous bubbling may indicate a large leak or a system issue within the chest tube components. The suction is often set at negative 20 centimeters of water pressure, but some patients are managed to water seal or gravity only. So the applying um, active suction is not always what you'll see. Um, During transport, very important to keep the chest tube system itself, below the level of the chest to prevent any backflow. Always ensure that it's upright and secured to the stretcher. You don't want that thing, dumping and moving all around. And try to avoid clamping the tube except for very specific reasons ordered by a physician, because clamping the tube in a patient with an air leak can precipitate a tension pneumothorax. Test tubes in general are very fickle things. They can and they do and they will misbehave in a transport and really in any environment. And as a result, you should have a systematic troubleshooting approach. If you see a sudden loss of titling, which is the rise and fall of fluid with respiration, so as the patient breathes, or if you see bubbling, immediately check the system for kinks, for dependent loops, for clots in the tubing, or even a disconnection. If the patient develops new respiratory distress or hypotension, you should suspect that the tube may be occluded or even dislodged, and that the pneumo or the hemothorax is reaccumulating. Um, if the tube accidentally comes out, you should place an occlusive dressing over the site and don't attempt to blindly reinsert the tube in the field or aircraft unless you have, direct order from a physician, as that is typically a hospital procedure. Um, a persistent large air leak, that should tell you that there's an ongoing communication between the airways and the pleural space. In those patients, be very careful with PEEP, be very careful with altitude, and be prepared for the possibility of a recurrent um, tension pneumophysiology. As with almost all things in medicine, especially transport medicine, certain special populations, certain patients require even more caution than in general. I can't speak. Pediatric patients, they fall into that category for sure. They've got smaller chests, smaller pleural spaces, and they can decompensate very quickly. Your equipment should be appropriately sized, and your threshold for escalation should be lower. Um, Patients who are anticoagulated or on anticoagulants, if they're on warfarin or heparin or DOAC, um, they are at higher risk of hemothorax and bleeding complications from both the pneumothorax itself and from any procedures that you do. Um, Ventilated patients are probably the highest risk for barrel trauma, which is a small pneumothorax that might be observed in a spontaneously breathing patient that can rapidly become life-threatening under positive pressure. Obese patients and those with chest wall deformities, they certainly have more challenging landmarks and thicker chest walls, which complicates both needle decompression and chest tube placement. Knowing these challenges ahead of time can help you to plan your approach rather than being surprised and freaked out mid transport. Let's take a look at some flight and transport considerations for patients with pneumothoraces, um, needing needle decompression, or those who have chest tubes. In air medical transport, Boyle's law is not an abstract physics concept. It directly affects your patients. So Boyle's law, as ambient pressure decreases with altitude, gas expands. That means that any air in the pleural space will increase in volume, and a small, clinically silent pneumothorax at sea level may become a large symptomatic one at a cruising altitude in a helicopter or an airplane. Um, Before flight, always screen high-risk patients, those with chest trauma, those who are on high PEEP, those with any known small pneumos, and discuss it with the physicians on the ground, whether a prophylactic chest tube is appropriate, because they'll want to put one in there, so it's in place during flight. Um, in flight, always monitor closely for changes in your respiratory status, in airway pressures and in hemodynamics after the ascent and during any turbulence, both of which can have a big impact on worsening the air in the pleural space. Um, on landing, so on descent and landing, and during transfers between stretcher and bed, always make sure the chest tube systems stay upright and below the chest level. These are the moments when systems get knocked over or clamped inadvertently and can have pretty serious adverse effects. Um, Always handle with care and understand where it should be placed, um, and do best by your patients. All right, I'd like to end this lecture by walking you through three scenarios that kind of tie things together. Maybe not everything, but some things. So take a look at case one and just think with me. I mean, it's tough doing this online, and I've said that a million times, but it really is because I would love to be able to have a dialogue with you, to have call and response and ask questions and things like that. But humor me, I guess. Okay. Um, I want you to picture for case one a blunt chest trauma patient whose vitals are deteriorating in ground transport. So breath sounds are decreased on the right. The patient is hypotensive and tachycardic, and ventilation is becoming difficult. Um, think about when you might pull the trigger on needle decompression and exactly how you would do it. Okay. Um, in case two, imagine a ventilated ICU patient with a known small pneumothorax who suddenly becomes hypotensive with rising airway pressures in flight. I want you to tell me or think about what you suspect, how you would diagnose it rapidly, and whether or not you should decompress the space. And then finally, in the third case, consider a patient with a chest tube to suction, okay, and an ongoing air leak. Think about or think through how you would manage that tube and the drainage system, what you would watch for in terms of recurrence, and how you would react if the chest tube dislodged or clogged. These cases are pretty pretty well-rounded synopsis to bridge the theory to with the clinical um, cases that you'll actually see on shift. Um, Key takeaways are here. um, all right, so let me close this one with the big points that you should carry into practice. All right. Any pneumothorax in a transport patient has the potential to deteriorate, even if there's needle decompression, even if there's a chest tube in place, and particularly under patients who are receiving positive pressure ventilation or with altitude changes in flight. Um, Tension pneumothorax is fundamentally a clinical diagnosis. If you strongly suspect it in an unstable patient, please treat it immediately and do not wait for imaging. Needle decompression is a bridge, uh, not definitive care. So whenever possible, you want a chest tube in place for ongoing decompression and drainage while en route. But if not, then needle decompression and consistent or even constant monitoring for any signs of air reaccumulation is extremely important. Um, And then finally, safe transport of these patients depends on vigilance. Constantly reassess their breath sounds, their work of breathing, their airway pressures, their hemodynamics, the chest tube function. Make sure all the lines and the tubes are secure. Uh, if you if you have a plan, always have a plan. Have a plan for what you'll do if the patient deteriorates in the back of the bus or in the aircraft. If you can do these things consistently, you will save lives with this knowledge, and you'll, I mean, you'll really impress those around you.